like access to culture. So they had to make a lot of decisions based on that. So just be mindful of that. I know maybe they've put this already, just understanding what is the local guidelines and context, so that especially if you're traveling and working, so you can, be sensitive to that. So what we'll talk about, and this is actually a table in the U.S. guidelines, sort of how you might think about, what might lean you more towards favoring treatment initiation earlier or empiric treatment, or when some of the things that might factor in your decision to wait. And so the things we'll talk about are some patient factors, some of the laboratory studies you may or may not have available to you, how they're doing clinically. Obviously someone's critically ill, a newborn, the impetus to start treatment pending work on the culture results is going to be a lot faster. Also your clinical context, I can say, I was practicing what's going on, we felt like everybody had to at that time at least, and so we were starting treatment a lot, without, with the chest X-ray and stuff. So just kind of think about some of those things. So with that in mind, I'm going to talk to you about a patient here for quite a number of years ago. So she, before I was seeing her, so she was 26 at the time. She was originally from Honduras, and she originally presented her primary care provider health, kind of for a well-visit exam, but also said, hey, I've got this cough, provider was using on exam and offered her an inhaler to schedule her for it's not too outside, but it's not reasonable. And the primary care provider said, well, I'm not really sure what's going on. If you feel worse, you'll come back and see me, and we'll do more workup. So she did make it back to the PCP, but she did go to urgent care. And see if you could raise eyebrows in the back. So I know you said, was like, so, minor nodularity throughout, some upper lobe, large nodules. So this is, and you'll see later, miliary TB is a little bit of an atypical presentation. With these larger nodules in upper lobes, we'll see. But the chest X-ray was read as an atypical pneumonia, and I think maybe what happens to a lot of us is maybe time until the X-ray is not really available. We look at the reading and you do what we do. And so what happened is she ended up getting azithromycin and didn't get evaluation for TB at that time. But if we sort of reflect back, she had lived previously in a TB endemic area, and her radiograph is consistent with TB. And she had this non-specific cough. Wheezing doesn't really fit with TB. You can really see that. So anyway, things to think about, but that didn't happen, unfortunately. So 5 months later, she goes back to her PCP and it's like, gosh, I'm still coughing, and now I've had a weight loss. So back to our patient. So she, you can see her chest CT there. So the primary care provider said, gosh, I don't know what this is. Got a chest CT and referred her to pulmonary. She was seen by pulmonary. And they said, we'd love to bronch you. She didn't have health insurance. And they said, well, it's going to be $250. She didn't have the money. And so she left. But she kept getting worse, presenting to the ER multiple times with headaches and then eventually somnolence. And then after, I think it was like 7 or 8 visits to Denver Health, the family, when she was somnolent, took her to a different hospital. And then she did get an MRI at that point, and she had leptomeningeal enhancement, LP consistent with meningitis, and her MTB PCR was positive. And so, the MTB PCR being positive is really telling for a number of reasons, because it does reflect organism burden. Often, TB meningitis is a clinical diagnosis, as we'll hear about. So clearly had quite a bit of progression over that, 7 or 8 month period. And so then, I'm going to keep going. Let's see. So this, okay, here we go. Sorry about that. So then she does get a workup for TB, for pulmonary TB. She gets bronched, and it was smear positive. And she had some additional studies. She developed seizures. She was in the ICU. She was started on appropriate treatment at that point. And by the time she was discharged, she was profoundly debilitated, confused, and really needed a lot of support and caring for herself. And this is the other layer of complexity, is that she was living with her two sisters, still doesn't have health insurance. And so as the TB program, we do our best to support the family and try to figure out how we're gonna pull all these resources together. So none of this needed to happen. It's a tough case to think about if, the things had happened earlier. And, honestly, it's kind of a sidebar. I don't necessarily fault the providers. I mean, we are a low incidence setting, and it's very difficult to detect a rare disease when you're in a busy primary care clinic. And, my sort of advocacy around that is we need better systems to support providers so that things like this don't happen. So when do you start empiric treatment? So, if people have life-threatening TB, we've already talked a little bit about that. And then certainly I think the public health reasons can be really important. Cultures take 6 weeks. People can't be out of work, can't be separated from their family that long of a period of time. And so the public health reasons to return to school, return to work, especially if someone has TB infection and you're thinking you still need to address their TB infection if they don't ultimately have active TB, starting empiric treatment, there's a lot of benefits to doing that. You do need combination therapy. As you'll hear over and over again, you don't treat TB with more than one drug. And so the standard treatment duration or standard regimen that's been around for 50 years, I'm not that upset, it's fine. We do have a couple new options. INH, rifampin, pyrazanamide, and ethambutol in combination. So there is a role for each drug in the regimen that, some of which we have a really good understanding of, and some of which, like with regard to PZA, I think we're still trying to understand exactly how it plays a role in the regimen. We have some idea, of course. So for rapidly killing bacilli, it's INH primarily, and then also fluoroquinolones. And then a sterilizing effect you see primarily with rifampin, but we also think PZA plays a role in this as well. And then the protection against acquisition of drug resistance, actually probably the workhorse in that, and among those options is ethambutol, and specifically protecting against emergence of resistance to rifampin, but INH can play a role as well. In any given person, if you have a population of TB bacilli, a number of them are already resistant inherently to one of these agents. And so that's the other reason to have combination therapies, is you don't start selecting for those subpopulations. So the standard regimen is to start with 4 drugs up front, and then once you have susceptibilities back, and you know that the patient's fully susceptible, you can stop ethambutol. Often that's sort of right around that 2-month period, and then people can go on to the continuation phase with INH and rifampin alone. Again, if they're fully drug susceptible, including to PZA. And then the typical duration, we'll talk about some of those exceptions, would be 6 months. So I put in this picture so that, if you haven't seen the regimen for the average sized person, it's a lot of pills, and even just the pill burden itself can, lead to vomiting. I may have had patients who, looked at the pills and literally got sick. And so it's just a thing to think about and to warn people about. The other thing people are, will pick up on is that it's not, you say 4 drugs, but it's not 4 pills. It's a lot of pills unless, you're operating in a setting where you have fixed dose combinations, and then you can manage the pill burden a little bit better. So this is just to give you a snapshot and really to remind you to go to table 3 in the US-based guidelines, and then WHO has dosing recommendations as well. So we use weight-banded dosing for pyrazanamide and for ethambutol. And so there's a separate table for that that I usually go to. One thing that I also want to point out is rifampin. So there is some weight-based dosing that's in here. Originally when we were deciding about dosing, or I say we, but I wasn't around for that. When dosing was decided on for rifampin, there's actually a big factor that's considered in terms of the cost of the medicine. And I think at the time, folks were erring on the side of lower dosing for rifampin to try to balance some of that, unfortunately. And now there are more studies that are emerging to show that higher doses of rifampin are safer, and some emerging data in terms of treating TB meningitis. So I mention that because sometimes people, you might be treating someone who's, 46 kilos, and I typically will upsize their dose to 600 milligrams, and people do fine when you do that. And so I would err on the side when you're choosing a dose to increase the dose, because most of the time it's very safe and probably more effective for the patient. So we've moved more, when I started caring for people with TB a number of years ago, at least in the US, there was a big push, we were using intermittent therapy pretty commonly. And now we know, as you might imagine, more drugs are better for people. And so there has been a gradual move, I think, in the right direction for people to take treatment every day. And so daily observed therapy for 5 days a week with self-administered doses on the weekends. So you can get to, full treatment for 7 days. So, there actually has been a number of controversy over the years about self-administered treatment for active TB, even pulmonary disease, versus DOT. And it really is because it's difficult to study this in a clinical trial setting, because DOT often isn't just giving people their medications. There's some wraparound services that can also, they're hard to measure depending on a person's program. And so on balance, at least US-based guidelines and WHO to a large degree as well, we do recommend using directly observed therapy. It hasn't been shown to reduce mortality, treatment completion, or relapse. There's a little bit of data that might reduce emergence of drug resistance. But again, I think it's hard to study this. And there are other benefits that we'll talk about in a second to doing directly observed therapy. But it can be difficult in practice, particularly if you're working in a small rural public health department in the US, or even if you're working in a rural, a less resourced area, like in Botswana, we didn't have healthcare workers, at least at that time, meeting with people every single day. It was every week, and then patients would choose someone to support their DOT. And so that's how it was done, because that's what we could do at that time period. So with DOT, the way ideally it can be approached is it is not just the medicines, it's addressing other social factors that we've talked about. I think it's really important, there's this imbalance in power that we have as providers compared to our patients. And we need to really understand that and try to do what we can to deconstruct that a little bit and realize that our patients aren't going to automatically trust us. And that's reasonable. You're meeting, if you're a TB, working in TB and you've never met this person, and now you're saying, no, you can't go to work. I want you to wear a mask when you're around your kid, all this stuff. And they're seeing that they're going to not be able to feed their family, or they're, all these limitations. You got to build trust with that person so that they can understand where you're coming from and why you're recommending all this stuff to them. And because, oftentimes, if someone's hearing that they're going to need to be isolated, they've got to take all these pills, they're worried about all these other things, you need to be worried about those things too. Because if they're worried about those things, then they're not going to be on board with the treatment plan. And so their priorities are your priorities, and TB is often not the first priority. It's other stuff. And so meeting those social needs is really critical. And it may not be you as the provider. We had a team-based approach, or still do at the TB clinic, and it may be that, a patient just doesn't really resonate with me, we're just not connecting, but their outreach, the outreach staff that's meeting with them is bonding with them. And that's great. As long as there's someone that they can connect with, so then that way, we can carve out their treatment plan or care plan accordingly. It's really important. And that takes time. It may not happen right away. And then also being flexible. So with DOT and using video technology, so that's something that Denver Health has used for quite a long time. So video DOT, and there's now guidance out in place about how to do that here in the US. And then being flexible. I mean, one of our first video DOT patients was a guy with cavitary pulmonary TB and uncontrolled diabetes, and he was a truck driver. And he was like, if you isolate me for 2 weeks, I'm not gonna be able to work. And he was by himself in the truck, and I was like, okay, well, then that'll be your isolation. And we put him on video right away, and he did fine. So, again, it's you got to meet people where they are and try to figure out how to make the plan work for them so that they can stay on treatment. So, the other things that can happen is, people can feel very depressed, feel very isolated, and again, that may not be you, but trying to figure out who they can connect with, even if it's someone in the community, is also really important. And then the way we try to do this in Denver, which I know varies by practice setting, is, if somebody's in the hospital, we try to do a warm handoff with the provider, so I used to talk to people personally, like, tell me what's going on with someone, and then we try to get them to TB clinic same day or next day, just to kind of make that connection with the patient. Sometimes, oftentimes we'd send outreach staff to their hospital room so they could start to build that relationship and rapport. And then once they've done that, to start asking, about their contacts, because the relationship needs to come first before people trust you to say who they've been around. And so just trying to make those connections as much as you can. And then, sometimes people do have FMLA. And so, it may be you as their sort of primary provider for that, sort of event. And you might be filling that out too. I'd say in my experience, most patients don't have that. And I've certainly had patients fired from their job because they had TB. It's not supposed to happen, but it does. And so, being sensitive to that, at least in Denver, there are actually came since COVID, a group of lawyers that are pro bono that can help people with some of that stuff. So, learning about that in your own community can also be helpful. So not only, excuse me, do we see this locally, we see this globally. People can face devastating costs, both direct and indirect costs, as a consequence of being treated for TB. We do know, this is from WHO, so it's looking at GDP per capita and incidence of TB. So you can see that in areas where there's higher GDP, there's lower incidence of TB. GDP is a very crude indicator of resources and wealth within a particular area, but I think it just underscores the need for us to understand some of the social determinants a little bit greater, and all the barriers that people can face if you're living in an area where there's lower GDP. You yourself or your community that you're interfacing with will also probably have limited resources, and maybe and also higher risk for TB. And so when it's possible to have patient assistance funds or incentivizing patients or compensating them for being on treatment, I think that can be a really important component of helping people stay on treatment because of all of these other competing priorities. And even more so for drug-resistant TB, where 87% of people with drug-resistant TB reported catastrophic costs. So catastrophic meaning they might lose their house, they can't, there's not enough food in the house, all of those things. And I've also seen people, about to lose their mortgage with drug-resistant TB here in Denver. The Denver Health TB Clinic has a patient assistance fund to offset some of those costs for patients, but I know that's not true everywhere. And so figuring out what's available is important. So that's the social and the sort of treatment setup. And then there's the monitoring piece that can come in. And so this is just a loose guide that you'll also find in the guidelines. So you want to do some basic laboratory tests in the beginning, including testing for HIV if that hasn't been done. Sometimes a lot of this has been done. And then monthly monitoring, the sort of the key things is doing a quick visual field exam because people are on ethambutol, at least in the beginning. And then testing for color vision as well. And then constantly assessing for symptoms. We're going to hear a lot about treatment toxicity with Dr. Griffith in the next talk, so I won't spend too much time on that, but asking people how they're feeling, how they're doing, because sometimes hepatotoxicity can be pretty subtle, as we'll talk about. So there are times where you're not able to offer daily therapy, and it's usually related to some of the social situations people are facing. Could also be short staffing with DOT. And so it is still part of the guidelines. It can be used, but you need to be really careful about implementing that in patients with cavitary disease, and it's not recommended at all to use intermittent therapy for people living with HIV. So that's sort of the standard approach. And then what does the guideline say? Well, what if someone can't take PZA or they're intolerant to INH or what's happening? Some of the stuff that, so there's this blanket statement. Well, you can use some of the principles for drug-resistant TB. We're going to hear a talk about that. So again, you kind of have to try to do your best to meet people where they are. And there are a few guideline recommended alternatives. So this is someone I cared for more recently, and she had uncontrolled diabetes, she was uninsured, and and was diagnosed with cavitary pulmonary TB on top of everything else. She had quite a number of bills to pay related to her move, and so she was having a lot of tolerability issues and was working 2 jobs, one of which was painting. So she was getting dizzy when she was sort of looking up. And after 20 weeks of trying to sort of pull this together, she's like, I can't do this. Like, I just can't. I've got to prioritize my jobs. Like, that was her focus. She, was the primary breadwinner in her family, and that was it. And, so I said, okay, but you kind of have cavitary disease and uncontrolled diabetes, and we, kind of need to figure this out. So we talked about a lot of different things, and what we ended up settling on was, so this is her x-ray midway at 20 weeks, which was remarkable because you can barely see the cavity in her left upper lobe. So at least I felt a little bit better. Didn't love going to a once weekly regimen. It's not recommended to do a once weekly regimen in the vast majority of situations. But this particular regimen, moxirifapentine, has actually been studied in people with cavitary disease. And so that was what we ended up settling on. And she was okay to do once weekly DOT in person. And then when we met with her, we would give her a grocery card to reimburse her for her time in meeting with us. And then we were able to get her we wanted to get her to 39 weeks. We were able to get her to 36. And then, she kind of disappeared from follow-up, but at least we were able to kind of get her through that piece of it. So then what is this regimen? So I call it the forgotten arm of Rifaquin. So there's been this move in TB treatment still today where we're trying to get to regimens as short as possible, sometimes sacrificing tolerability. We'll talk about that. And so this was one of those treatment shortening arms, but they actually had a 6-month arm. And 63% of the patients enrolled in this trial had cavitary disease. And so one of the arms, so the 6-month arm, was patients started with moxifloxacin, ethambutol, rifampin, and PZA daily for 2 months, and then received once weekly moxifloxacin and rifapentine. And you can see, I think this is the one that's working. Well, my pointer isn't working, but you can kind of see that the 6-month arm is very similar to the control arm in terms of efficacy, and was actually pretty well tolerated. And so this is mentioned in the US-based guidelines as a potential option, also kind of mentioned as a possible option for INH-resistant disease, even though it wasn't specifically studied in that population. So it's just something to think about. I certainly wouldn't lead with this regimen. It's a high pill burden. Still would sort of try to hold to daily therapy is better, but there are going to be selected situations where this might be where you head in terms of TB treatment. So there also is a newer regimen, a newer, shorter 4-month regimen. It was published by the TBTC group in, I think, end of 2021. So it's a 4-month regimen that was either with or without moxifloxacin. So the 2 intervention arms had rifapentine in them. And so it was mostly people aged 12 years and older. And if a person was living with HIV, they had to have a CD4 count greater than or equal to 100, and then also be on an efavirenz-based regimen. Many exclusion factors. Also in this patient population, only 20% of the people enrolled were greater than the age of 45, and only 1% were greater than 65 and older. And so, for people who are older, although I don't think 45 is really older at all, still pretty young, this regimen wasn't studied in that population. And I think that's an important thing to think about. So what they found, they measured efficacy. It had a margin of non-inferiority of 6.6, and both by efficacy and grade 3, grade 4 higher adverse events. The arm with rifapentine and moxifloxacin was not inferior to standard of care, and you can see that here. The rifapentine arm only did not meet that margin of inferiority, so it was technically inferior, there's a lot of semantics, to standard of care. And so that regimen isn't recommended, but the rifapentine moxifloxacin arm for 4 months is now recommended as an alternative to the standard 6-month therapy with, a few caveats, of course. And the MMWR, so CDC now has published interim guidance about how you could potentially operationalize this. So there should be some more data coming out. So I know some of my colleagues in San Francisco and also colleagues in New York have tried to implement this. And it actually has been met with some challenges, and it's mostly around the pill burden and tolerability. A lot of the patients my colleagues in San Francisco care for are in that older than 60 age group. And so those are the patients that have had quite a bit of tolerability issues. I did try to pitch this to one of my patients last year and showed him the pill burden, and he was like, no. So, I think there are likely folks who could benefit from this regimen if people want to finish early. But I do think it's important to counsel people about the pill burden. And then if you're going to try to implement this, try to start in people who are young, under the age of 45, because that's the population that was studied in the trial in terms of tolerability. So I mentioned this isn't a regimen that's ready for prime time, but I think it's just interesting to think about how we might potentially move to shorter regimens, that 6 months isn't sort of this, the magical duration. So it's interesting. So this is called the Truncate TB trial. And what they did was they randomized people to a high dose rifampin linezolid arm, but also an arm with bedaquiline and linezolid, in addition to the standard treatment regimen, and then looked at efficacy. They had a pretty wide margin of non-inferiority of 12 percentage points, and also looked at grade 3, grade 4 adverse events. And so there were people at 8 weeks, so they would largely stop people at 8 weeks, but if people looked like they weren't improving, then they could extend an additional 2 to 4 weeks. So the vast majority of people in this trial got 8 weeks of treatment, and it's just remarkable that the bedaquiline linezolid arm was 5.8% versus 3.9% standard of care, so it wasn't inferior to standard of care. Now, I think some of the things that we worry about with something like this is, bedaquiline, as you guys will hear about, has about a 5-month half-life, and so even though folks had stopped treatment, the bedaquiline was still hanging around, for several months. And so, the number of people in this trial was pretty small. They're still, they follow people for a while, but it may not be enough to really detect emergence of resistance to bedaquiline, which is obviously a key agent for treating drug-resistant TB. The other challenge, I think, is just logistics. So getting bedaquiline, has anybody tried to get bedaquiline in the US? Yeah, it's like, still exhausted just thinking about it. Even when people have insurance, the prior auth gets lost and then you have to resubmit it. It's just, it's kind of insane. And so that, if you wanted to lead with this regimen, you can't, because you can't get bedaquiline. I actually haven't practiced outside the US in a long time, so I don't know if it's any better, but yeah, it's quite challenging here. So again, it's not ready for prime time. So don't rush to start using this regimen anytime soon. But I think it's just good to kind of hear that there's some thought and about how to potentially shorten treatment, and not necessarily sacrificing tolerability along the way. All right, so kind of getting back to sort of the standard treatment. So this is another patient of mine. So he originally was referred to TB clinic, had a positive IgRA and probable pleural TB. We evaluated him for pulmonary TB, and that evaluation was negative. And lots of coaching, so the best way, and you'll hear about this, to diagnose pleural TB is with pleural biopsy. Obviously, that's invasive. And some morbidity associated with that and hospitalization. So he's 67. He wasn't too enthusiastic about that, which is very reasonable. But eventually we did that. He had, and he did have necrotizing granulomas, and we were able to set it up for tissue culture. And he was quite nervous about PZA toxicity. And so I said, all right, well, let's start with, we can kind of lead, sort of gradually get you on PZA. So we started with IRE and then added PZA. And after about a week or so of being on PZA, he's like, my appetite's a little off. He's like, but I'm not that worried about it. And I said, well, I'm worried about it. And so we checked LFTs, and they were 5 times upper limit of normal. So It was pretty early into his treatment course. And so we ended up changing him to levoethambutol for a week. And then as his LFTs improved, slowly added back in rifampin. And it's a good thing we got cultures because he actually had INH resistance. And so for that minute, or the short period of time that he was on IRE, he was only effectively, on ethambutol and rifampin, which, isn't adequate. So we were lucky that we were able to get cultures. That's not always true depending on a person's practice setting. He did have tendonitis on levofloxacin, and caught that pretty early before he had any kind of tendon rupture. And then we were actually able to switch him to moxifloxacin. There's some growing experience, hearing about some differences in risk of tendonitis with fluoroquinolones, and it actually got better. So we were lucky that way. And so he kind of settled into a regimen of moxifloxacin, ethambutol, and rifampin, and slowly got better. And that's, we ended up treating him for 39 weeks. So, if liver disease is mild or LFT elevations are mild, you might start out without pyrazinamide as kind of the approach that I just took with my other patient. And then you can continue INH, rifampin, and ethambutol. If they're on treatment and you notice LFT elevations, you can, sometimes we'll pull out the PZA first. And then if they have sort of moderate LFT elevations, then you want to stop the INH and pyrazinamide or not lead with that. And then you can still try to do rifampin, ethambutol, and then substitute in a fluoroquinolone. If people have really high LFTs, upwards of 10 times upper limit of normal, or they already have cirrhosis, then you wouldn't, I would hesitate to even use rifampin. And so then you would use an alternative regimen, some of which I've listed here, although I wouldn't wish cycloserine on anyone. You'll hear more about that drug in the next talk. But there are alternatives that you can use. And then for renal disease, so this is another patient of mine. He had hypertension, actually presented in renal failure and in need of dialysis when he first presented to care. And also had disseminated TB. We think that his renal failure was probably related to hypertension, wasn't really related to TB, just happened to have both things happen to him at the same time. And eventually, so he obviously had disseminated disease. And so in terms of how you dose for renal disease, so there's three medicines that you worry about. So it's pyrazinamide and ethambutol, which are primarily renally cleared. And then obviously we're using levofloxacin. And so for PZA and ethambutol, you use the same daily dose, so that weight-based dose, but you drop the interval when their creatinine clearance is less than 30. And so, sometimes you'll have people, and that's true for dialysis, someone sort of hovering on the edge, you might have to watch their renal function pretty carefully, but that's how you would approach that. All right, so then sometimes there's situations where you just can't offer that standard regimen. So this is someone that we also cared for. So she was 24. She'd recently traveled and was living in India and working here in the US. Had come back after visiting family and was in shock, intubated, found to have TB. So she had miliary disease. And then she was also found to have an esophageal perforation. And you can kind of get a glimpse of that in the CT scan there. And then if you don't have to be a radiologist to see the pulmonary embolus. Everybody see that? It's pretty obvious in the back of the room. So she was in PO. And so, they couldn't give her anything after her esophageal stent. And the team wanted to give her lytics. So there's a whole other discussion about anticoagulation and drug-drug interactions that I'll save for later. But so now it's like, well, okay, pyrazinamide and ethambutol are only available orally. And INH in theory is available IV, but I've always had trouble getting it. And then there's rifampin. And so, here's a situation with someone who's critically ill from TB. And so you absolutely need to pull together a regimen for her so that you can stabilize her in addition to all the other things that's going on. And I know this is an unusual situation, but I have seen people die who they thought that the gut was working and they were in the ICU and they just kept giving the TB meds down the NG tube. And so I bring it up because I don't want everyone to ever be in that situation again, because there are alternatives, there are IV alternatives, and it's mostly related to how you would approach drug-resistant TB. And so how you can sort of pull this together. So if you can get IV rifampin, you can use IV amikacin, you know, meropenem also can be given, and then moxifloxacin and linezolid. So that's how, those are some of the options. You'll hear more about those drugs in the MDR talk. And so you can start with a regimen like this, and, you know, the stewardship people might get a little upset. I'm seeing Jared in the back. So don't tell him I told you to do this. But you know, at least to kind of get people stabilized, and then slowly you can switch them over to a standard regimen, you know, once they're able to do that, or they're able to tolerate orals. So it's just something to think about. Okay, I kind of mentioned this earlier, but I do want to highlight that, you know, the population of people with TB is aging, and it's not just in the US. People above the age of 65 comprise about 20% of people living with active TB. In the United States, and other countries as well, so Japan, China, Vietnam, and others. They're seeing that we're seeing people getting older, and we know, we've observed that people in this age group do have higher risk of toxicity and tolerability, but we don't know exactly what's driving that, if it's medication interactions, if it's frailty or other comorbidities. And so the optimal regimen is really uncertain for this age group. You know, the guidelines sort of loosely recommend maybe you hold PZA for people who are age 75 and older, then you're lengthening treatment automatically. And then of course, like in my patient holding PZA, he had INH-resistant disease. And so, you know, it's an unmet need. So I don't necessarily have any answers other than hopefully some of you will advocate for that. And, you know, sort of think about how you might try to, you know, evolve a regimen, or, you know, be more responsive in your regimen in someone who's a bit older, or monitor them a little bit more closely for adverse effects. So one regimen that sometimes we end up landing on, or, you know, that there actually isn't a lot of data for, just like my other patient who's on moxi A and B rifampin, is this regimen of fluoroquinolone plus ethambutol and rifampin. So there've been a couple of observational studies that have looked specifically at this combination in people with INH-resistant TB. So, you know, really small numbers of folks. You can't really look at efficacy per se with that small number of people, but, you know, we can say that patients tolerated that regimen okay, and, you know, at least in the close follow-up that they had, didn't have any evidence of relapse. So again, not a regimen I would necessarily lead with, but it might be a regimen that you land on if your patients have problems with toxicity and tolerability. So when do you extend to 9 months? And so this is another area where it might differ based on practice guidelines. So, you know, for pulmonary TB, WHO guidelines don't recommend to extend to 9 months for really any reason. But, you know, here in the US, or I would say in a setting where you can follow cultures, we would extend to 9 months if people are culture positive at 2 months of treatment, or cavitation. So the guidelines really focus on both of those parameters, and it's related to an older trial from 2001 or 2002, where they followed people for 2 years. And in that particular trial, people who got 6 months of treatment, their risk of relapse in 2 years with cavitary disease and culture positive 2 months was 25%. If you had one or the other, the risk of relapse was 10%. So the 9-month extension hasn't really been studied. Again, it was kind of a group of experts in a room saying 9 months sounds reasonable. So that's kind of, and that may be in part why WHO hasn't fully endorsed it, because there isn't a tremendous amount of data to support that extension other than that one trial. But, you know, how long to extend, I think, is where there's some uncertainty. If people have involvement of bone or joint without hardware, you would go to 9 months, and then a lot of experts would extend to 12 if people do have hardware in place for meningitis, but also with a low threshold to extend for 12 months. And then other sort of considerations that are implemented in a few practice settings. So there are a few places, I think Hong Kong is one of them, where they pretty readily extend to 9 months if people are living with diabetes, particularly if people are on insulin. But that's a consideration. It's not a firm recommendation. that's evidence-driven. It's just something to think about. And then on the flip side, if people have possibacillary disease or culture-negative disease, so the person who has an abnormal X-ray, you do the cultures, you're starting them on empiric treatment, perhaps, and then the cultures are negative, and then maybe they have radiographic improvement, they have symptomatic improvement. So for people who have culture-negative active TB, you can safely treat them if they have PZA in the regimen for 4 months, and that's also in the guidelines. So then what happens, when life gets in the way and people have to interrupt treatment? So if it's more problematic if people end up interrupting treatment in the beginning. And so if people have more than a 2-week interruption in the initiation phase, you really do probably need to start over. If it's in the continuation phase, it gets a little bit trickier. And so, we count treatment weeks and are pretty careful about like how many doses would define a treatment week, So because sometimes you'll have people who might take 4 days out of 7 of a daily regimen. So that's not really completing a treatment week. And so you do get in a lot of the details about that. So there are some references that you can look at in the guidelines for how to, like when you encounter that, how to advise people about how to extend their treatment. Let's see, and this one, okay. So, even when people take treatment perfectly, there are folks who, may not respond to treatment as we would like. And so, 99, the proportion of people in that group is about 5%. So, but if people who are continuously positive for cultures at 3 and 4 months, are considered to be probably on track for treatment failure. Treatment failure is defined as if you're still culture positive at 4 months. And so, I actually start to get a little nervous when I see people culture positive at 2 months, and then by 3 months, it's like, all right, what's going on? Especially if they've been doing DOT, there's a lot of different practices about doing drug levels. Some people will lead with doing drug levels if you're able to do that up front. Our practice in Denver has not always been to do that. But certainly after 3 months of treatment, if people aren't responding, I would absolutely do that and start, double checking for adherence, even if people are on DOT to make sure that you know what's going on. And so, how do you manage that? So if people are seriously ill, then you can add 2 to 3, you can expand out their regimen while you're trying to figure out what's going on in terms of drug levels. Have they had emergence of resistance? You'll be repeating cultures and imaging. If people aren't seriously ill, and you're worried about resistance, which certainly would be a concern at that point, you could potentially hold treatment. That can be problematic if they're still culture positive, they're trying to stay at work. There's a lot of factors into that decision. But it could be an approach while you're getting more information and thinking about how you might evolve their regimen. So, when you think about TB completion of treatment, it really is the number of doses and how you're defining that treatment week. And so ideally, you'll have people taking all of their, like that 2-month period, if they're missing, having some gaps, if they can get that within 3 months, then you go ahead and count that as their initiation phase. So there is some flexibility there. And then for the continuation phase, you can consider people complete if they've had all of their treatment weeks within 9 months, if they've had gaps here and there. So one thing that I think it's not in the guidelines, and I think a lot of people do this differently, is how to follow people when they're finished. There's no consensus about the approach, but I do think this is another call to action on my part to try to bring folks together to think about how we might do this. If resources allow, as we know that the risk of death amongst people who've had TB is quite high, almost 3 times higher than someone who's never had TB. And people can have lingering respiratory symptoms related to post-TB lung disease and bronchiectasis, and then get NTM on top of that, up to 31%. And then there's other things too. It is hard to kind of re-enter a person's life after you've been on treatment, especially if you've been isolated. So there can be an unmet some mental health needs and concerns in patients as well. we as providers or as infectious disease clinicians, we can't do all of that. But I think, again, figuring out what's available as a source of support, trying to reconnect people with a primary care provider is still really important for follow-up. All right, so to kind of pull this all together, so as I've mentioned, it's important to treat the whole patient, their social situation, think about public health parameters and the individual patient factors when you're starting and continuing TB treatment. And there's absolutely a clear role for empiric therapy, depending on the scenario. And, as I've kind of mentioned, it is good to have an overall approach and to follow the guidelines as much as we can. There's been review, they're evidence-based. And then sometimes you do have to kind of, meet people where they are and try to create a regimen that is as evidence-based as possible to try to help them stay on treatment. Treatment, for TB, even 4 months is a really long time to be on treatment. And so it really is important to establish trust with your patient and their household members and their community and do your best to maintain that. And it may not be you personally, but the team. And as even though I've mentioned a lot of different options, the vast majority of people can still complete treatment with the standard regimen and do well with 6 months of treatment. Okay, so with that, I think I have 10 minutes or so maybe for questions.
Okay, questions?
Thank you. Michelle, I was just wondering about the weight-based dosing of rifampin.
Yeah.
There is a zealous advocate for that, Chuck Pelican in Florida, who goes around the country demanding that take place. What's the problem? Why haven't we seen guidelines that allow, for a guy who weighs 100 kilos, 600 milligrams is not a lot of medicine.
Yeah, I agree. No, I think my personal opinion is that we can and probably should be a little bit more aggressive with rifampin dosing in particular. I mean, when you get into 35 mg per kg, you can start to see adverse effects related to rifampin, but short of that, I think it's reasonable to be a little bit more aggressive.
Thank you. It might be a very practical, easy question, but with regards to when you're starting somebody on the ethambutol and you're doing like vision screening, in my practice, I think we tend to send people to like ophtho, but like, is there like an easy thing you pull up on the computer or like a handheld that you're doing regularly?
Yeah. So we'll just do an eye chart in clinic.
Okay.
And then we have the old school Ishihara, but you can get that online too, and scroll through the images.
And so is there any point at which you're sending them to like an eye care provider during?
If they have I think if they have visual complaints at baseline, I would send someone. If they develop visual complaints, I would send someone. But other than that, we hadn't. And, I mean, in the 10 years I was over there, I had one person with optic neuritis from ethambutol. So, but we only give ethambutol generally for 2 months. So that may be part of why we don't see it as much.
Thank you.
Yeah.
Most optic neuritis occurs between evaluations. So, don't get too comfortable knowing that you're sending the patient to an ophthalmologist because it's going to happen in between. And so probably what's more important is to have them read the same font every day. They'll pick it up before the ophthalmologist will pick it up. So, the same magazine print or newspaper print. And also to empower them to let you know, to stop it and let you know, as opposed to let you know and wait, not in your case, but in my case, a week before they hear back. So empower the patient to stop when it's visual related. But if you look, and I've been involved in some legal cases over the years, it's amazing. The doc ordered the visual acuity checks. It's happening every month on time, and the problem happens right in between. So yeah, we need to just be more aggressive, I think, about monitoring. fortunately, it's pretty unusual.
I was wondering if cavitary disease in regular TB ever affects the regimen or duration of treatment you want to give. And two, someone that has cavitary disease, how long through treatment, or what conditions make you feel that that person is no longer infective and able to get into the system again, just reduce risk for spread?
Yeah, so for cavitary disease, it extend to 9 months with for patients with drug susceptible TB. I would do that pretty readily. I don't know that everybody does that, but that's what I would do, because the risk of relapse is maybe about 5 to 10% at 2 years. In terms of infectiousness, so we have pretty crude indicators for infectiousness. We usually still, often will rely on smear, but our practice in Denver has not been I know other public health programs will continue to check smears. Smears can pick up non-viable organisms. And so our approach has been, if people have, or smear positive, it's mostly based on smear, not necessarily cavitary disease, we would recommend isolation for 2 full weeks of treatment. And then if people are clinically improving and we know they have drug susceptible disease, we don't recheck. We tell people they can go back to work at the end of that 2-week period. There will be some updated guidelines about length of isolation that NTCA has been working on, but then I'm hoping they'll publish maybe later this year. And I think for certain situations, it might even be shorter than that, but stay tuned. So, yeah.
Is there time to put up the interruption in care or treatment slide? Just so I can jot notes.
Yeah. And this is in the guidelines too. Yeah.
I was just looking at this again.
Oh, yeah.
So I actually wrote that.
Yeah.
And so I'm looking to see what I wrote. Because it was a long time ago.
Yeah, it was 2016. I think we're due for.
Well, I was
update.
charged, we all get charged to do something.
Right.
And this was one of mine. And what I wanted to say is that most of this is not evidence-based.
Right.
It's more programmatically based, made sense, wouldn't be too onerous on the patient or the program. But the 80% was evidence-based, because when you look at the British Medical Council and Thoracic Society's trials, to say that a person completed therapy, you had to complete at least 80%. So when you look at the results, it wasn't the results of people who completed 100%, it was 80% or more. And so if you complete 80% or more, those are the outcomes that we quote to everyone. And so that's where the 80% came from. Anyway, so someone had a.
Yeah. Wait, I think she was first.
Thank you. We are having a lot of eye-related TB. I was wondering if you have any suggestion how to treat that.
For ocular TB? Yeah, that's a tough one, because I don't know what your experience has been, but people will have uveitis, and then the ophthalmologist will do a quantiferon and it's positive, and then they send them to us, and then steroid drops get started, and sometimes the patient gets better. So it's muddled in terms of how to do it. So what I've done is if people are getting better on their steroid drops, which I know, everything can get better on steroids, I might wait a little bit to start treatment. If they're not getting, and then have them come back in a month or so. If I already know that they're not getting any better, just things are kind of not really changing all that much, then I will go ahead and start an active regimen. And admittedly, I've kind of waffled whether or not to include EMB in the regimen. Some people say, it is a different, uveitis is different from optic neuritis. I think I've sort of leaned more on not including ethambutol just to kind of keep things a little bit clearer, but other people do. And then, once I start them on a regimen, then I, will see them back at 2 months and see if they're better. And if they're better, maybe it was the steroid drops, maybe it was the TB treatment, you may not know, but I got, and if they're tolerating treatment fine, then I would continue on and treat them for culture negative TB. So that's kind of how I've done it. When it's subtle like that. I mean, there are certainly patients where it's quite obvious they have quite a lot of disease, and that I think, and I even cared for one person where they were able to sample the vitreous and we were able to prove they had TB, but that's pretty uncommon. And so for that, I think it's in some ways it's easier to figure out what to do, but it's hard.
Jim.
Thanks, Michelle. That was really great. This is kind of an anti-therapy question, so you'll be off the hook if you don't know the answer. But what is the current state of Colorado law in those that are non-adherent?
Yeah.
With therapy, you just can't get them in any regimen, and they're out there.
Yeah, so I mean, this has come up, or people who disappear. So, and you can kind of see the writing on the wall where people are struggling to stay on treatment for whatever reason. And so we try to step up our level of engagement, try to figure out who they could potentially interface with to try to get, and figure out what's going on. Like with the patient I was mentioning, it's like, what's the barrier here? Because most people want to get better. But when you find yourself in a situation where folks aren't able to stay on treatment or not willing to take treatment, it is really important to document all of that, what has been done to try to support the person to stay on treatment. And then you start telling, then you start sending them letters or informing them of their rights and what could happen if they're not able to stay on treatment. And all the while saying, being on treatment, it's your right to decline treatment, but it's not your free right to put the public in danger, and trying to say that in a sensitive way as you can, but being firm. And so you keep escalating, telling people, if you don't come in by this particular time period to complete an evaluation to see if you're infectious, you'll have to stay at home. And so we do have that right within Colorado to step it up to the point where you can get a warrant for someone's arrest if they don't stay at home. In my time over there, I think we did that twice. So it doesn't come up very much, and you can imagine it annihilates your relationship with that person. And so they're definitely not going to want to take treatment from you then. And so it's important to be careful and to really think about what their risk is. And so sometimes there's a several month delay before you kind of get to that point where you're seeking a warrant for someone's arrest. So we did reach that with someone last year who was off treatment and learned that he might be leaving the country. So we put him on a no-fly zone or a no-fly list. And he ended up surfacing later, actually, with relapsed TB. And then actually some other things that happened. So he ended up being incarcerated, also not because of us, but from some other things. And so then he was actually on treatment. But I know that varies by state in terms of how far you can escalate. But, yeah.
Okay, I think we'll, for the sake of time, move on. Thank you, Michelle.